All right. Thank you very much for that kind introduction. And it's a pleasure to be here with you today. And thank you for the invitation to present. It's a very important conference. And as I was hearing Mr. Dawes present, I was just struck by how much this movement has gone in terms of really putting a focus on social determinants of health, social determinants of education, social mission, and the need to address that within our health education and training of our future workforce, our current and future workforce. So I just thank you. It's a great honor to be with you all and humble. And I wish I could be with you in person. I hope that the next conference we'll have an opportunity to do that. One last thing before I start my remarks. I worked with Fitzhugh Mullen for years at Unity Healthcare. He always loved to say that I was his supervisor, his boss, which always embarrassed me to no end. I was always a student of Fitz, watching what he did in clinic, watching what he did outside of clinic, his tireless work ethic to address health equity, not only within his practice, teach that among his students and his residents and his trainees, but really exemplifying a life that we should all try to emulate. And certainly I'm trying to do the best I can in my own humble way. So just a tribute to him and an acknowledgement of his life efforts towards starting this Beyond Flexner Alliance and the important work that it's undertaking. You can go to the next slide, please. And I can't see if, not sure if the slides are being advanced, but there you go. Thank you very much. So just to set the context, I think all of you are well aware of the landscape, even before COVID. The growing demand for health professions is stronger than ever. I think the labor market, as all of you would attest and know, and certainly in the last few years, is stronger than ever. Professionals, paraprofessionals who want jobs in healthcare can certainly find them. They're in high demand, and certainly primary care is in very high demand. But at least part of that growing demand for health professions is as a result of a shrinking supply of several different disciplines, including primary care. It's also a result, in part, to the unequal distribution of that workforce across the country. And as Dr. Sklar said, like me to speak on both that supply and driving clinicians, encouraging clinicians, supporting clinicians to go into areas where they're most needed the most is certainly what we do day in and day out. But just to set that context in terms of what we're trying to address before COVID, during COVID, and after COVID. Next slide, please. Thank you. So our mission remains the same, which is improve the health of underserved populations, strengthening that health workforce, and most importantly, and to Dr. Sklar's point, and I think what we're really all after here is how do we support clinicians, connecting them to those skilled professionals to communities in need? How do we identify that need, and how do we incentivize and encourage students of all disciplines and all backgrounds to go into those areas where we need it the most? Can we go to the next slide, please? And when you look at our overall programs, we really have four simple aims. They're simple, but they're quite challenging in terms of our ability to make headway in each and every one of them. The first is access. And certainly, you can't just provide insurance. You can't just provide a provider and expect that quality access is going to occur, that the issues of health equity are going to result from that just occurring. We need to be intentional about the type of access patients and community members have, who they have access to, hopefully as free and easy as they can. But we really look at that access issue throughout all of our programs. But the supply issue now more than ever is right here, right in front of us, front and center. Whether it's the nursing workforce, the primary care workforce, the behavioral health workforce, the critical care professionals workforce, all of them have been hard hit by COVID. We don't know right now at the national level exactly how COVID has impacted that throughout these various professions, but we know it's going to be worse than when we started. And again, that distribution issue. Regardless of what we do on the supply, if we're not finding ways to share what these communities need, how providers can address those needs at the community level, I don't think we're going to hit the mark in this area as well. Next slide, please. So with that background, there's a couple of others, and certainly Dr. Dawes was very eloquent in this, and that is the racial inequity that's occurring even before COVID has existed for hundreds of years and now is with us again. We are seeing the results of that inequity playing out in terms of health disparities, life expectancy, again, access to care, and COVID. COVID has really shone a light, as all of you know, on both the racial inequity, the disparity, and the result of market forces and how it's impacted certain communities disproportionately. So we look at this landscape of healthcare delivery and workforce, and we were coming to the realization that we need to do a better job about engaging our key partners and stakeholders. The traditional partners that we've relied on to get this work done, we will continue to work with them, but we need to broaden it. We need to look at community-based organizations, particularly those that are training or have the potential to train the future workforce by identifying community members who have the aptitude, the potential, and supporting those individuals through the whole continuum of their health profession or allied professional education and training continuum. Understanding what needs there actually exist for workforce at the community level is critically important for us. I'll share a little bit of what we're doing there. And then looking across, in the introduction you heard, we had 40 programs. We have to get away and are getting away from just looking at one particular program and thinking that that is going to move the needle on whether it's access, the supply, or distribution. How do we look across our 40 plus programs and growing in terms of a portfolio and lever a constellation of programs in particular areas? Next slide, please. And when you look at our overall focus areas, obviously we're still focused on COVID and the equitable response to the pandemic. But for us, we're focused on three key areas: behavioral health, community health, and maternal health. Not only are these important priority areas and focus areas for the Department of Administration, but we believe we have levers within our portfolio to address each and every one of them. And cutting across all of our programs, focusing in on provider resiliency. And I think all of you recognize how COVID has decimated our workforce, has created a situation where we have more burnout, we have more substance use disorder, we have a growing rate of suicide among our health professionals and allied professionals. We need to do whatever we can, and we have put out some funding to support providers and organizations in that transition of wellness and embedding that culture within their organizations. And of course, when you talk about health equity, you really can't talk about that without talking about diversifying the health professions. For decades, and we have a number of long-standing programs that address, whose aim and purpose is to address diversity, 40, 50 plus year old programs. But unfortunately, despite their best efforts, we still see a lack of diversity in all disciplines among health professions. Next slide, please. So some of the strategies and drivers for success that we deployed, and I will draw your attention to the support for community-based training and the leveraging our loan and scholarship programs. This is something that we've undertaken the last few years to really intensify our efforts to support both the infrastructure and the capability of community-based organizations to do more training. So if the logic is you train individuals in that setting, they're more likely to go to practice in that setting. Then if you're identifying individuals from those communities and you can support them through that continuum of education and training all the way through into their practice, I think that logic holds that they're more likely to go into those areas. They're more likely to practice the type of medicine that we want them to practice for these community members. And we've seen that in our programs. Next slide, please. So I'll run through these for the sake of time, because I know we want to get to some questions and answers. But in terms of our pipeline of diversity programs, as I said, some of these are longstanding. The Health Careers Occupational Professional Program, HCOP program, is celebrating its 50th anniversary this year. That's a 50-year-old program that's been assisting students early on as high school, transitioning them into graduate school, pre-graduate school, health professional school for decades now. And when we look at some of that data, when we're able to look at individuals who have gone through that program, we see that holds true. That support of them through the health professions has led to many of them going into these communities where they're desperately needed. Next slide, please. So our loan and scholarship programs, the infusion that we've got through the ARP was historic for us. Almost 23,000 members joining the Corps this year. That's a budget of $1.5 billion that was used for the National Service Corps, the Nurse Corps program, and then another program that was supported as well, $28 million to substance use disorder and treatment program. These have been impactful. These offer opportunities that we haven't been able to offer before because we haven't had the funding to support applicants and lower HRSAs. So this has really been a game changer. In fact, we've been able to fund awards in HRSAs as low as 3 last year, and we anticipate doing the same this year. So really impactful in that area in terms of supporting clinicians going into those areas and creating a retention mechanism for them to stay in those areas. Next slide, please. So we look at our behavioral health program. This is a significant part of our portfolio. It's grown. The base program here, the Behavioral Health Education and Training Program, was created as a result of the tragedy in Sandy Hook in 2014. It was stood up in 2015, and since then, it has allowed HRSA the ability to expand the supply of behavioral health disciplines that it supports. Now, at over 150 million for that program alone, and when you look at the full constellation of behavioral health workforce development programs, in the 6 years that we've been administering those programs, there's been a reduction in shortage of those providers by 27%. And we project that even with level funding, by 2025 to 2030, we will have reduced that shortage by almost 50%, over 45% among those disciplines. So really an important part, especially when you consider what is happening to youth mental health and behavioral health services now, and the great need for those services going forward. Next slide, please. Our nursing workforce development program, as well, another important part of our portfolio. As I mentioned in the outset, COVID has really impacted our nursing workforce tremendously, particularly at the RN, LPN level, where you see a disproportionate number of them being nurses of color, coming from communities where they're trying to survive off the salaries that they're getting off of their nursing profession and have been struggling for the last few years. They've been drawn away to more lucrative travel nursing positions, creating an undersupply and a desperate need for nursing workforce, both in the acute setting and in the outpatient setting. Next slide, please. So a little bit about postgraduate training. Really a large emphasis. Our biggest program here is the Teaching Health Center GME. But this graph shows you over the last 5 to 6 years what we've been trying to do to have more sites providing education and training opportunities in medically underserved communities. So this is, again, one strategy that we've deployed over the last few years to try to create environments where ultimately our trainees and students will go work. Next slide, please. And if you look at FQHCs in particular, since we deployed, as an example, the nurse practitioner residency program, that yellow bar there, you've seen now 39% of those trainees training in FQHCs are lookalikes. This is amazing for a program that only has 25 million. So that increase in nurse practitioner students and graduates has been commensurate in our ability to grow this residency program. And over 50% of those who finish that residency either stay at that site or go work in other medically underserved areas. Next slide, please. So our largest program, our THC GME program, received $330 million through the ARP. And what's been significant in that program is our ability to deploy a planning and development notice of funding, a little over $23 million. But most importantly, 96% of the 47 awardees that we made last year are all FQHCs or lookalikes. This is amazing because of, again, that community focus on primary care, OB residencies, psychiatry residencies, pediatric residencies. And we believe with continued funding of this program, we'll have a disproportionate number of those graduates staying in those communities and working and providing those key services. Next slide, please. So this slide shows you, as I mentioned, our nurse practitioner residency model. It has a 2 to 3 year return on investment. That is, within that period of time, the data that we have indicates that they're essentially breaking even that with any additional revenue, they're going in and supporting the residency program. They're providing key services, and most importantly, those graduates continue to stay on in these areas or other like underserved areas as well. Next slide, please. So our resiliency dollars put out a little over $103 million to support awardees to increase their resiliency training for health professionals and public safety workers. But I'll draw your attention to the smaller one, the $28 million to support 10 organizations to support their culture of wellness. And this is significant since much of the intervention that occurs in this area occurs at the individual level. That is what individual clinicians may need, whether it's wellness programs or referrals to mental health services, or counseling, etc. What's significant about that 28 million, those 10 awardees, is that organizational factors that contribute to burnout, reduce resiliency, and all those unintended consequences of providing care in this environment right now need to be supported at the organizational level, and this funding opportunity does that. With any additional dollars that we get, our administrator is intently focused on supporting the resiliency of our current and our future workforce. And my pitch to her continues to be at that organizational level is where we need to continue to invest. And as Congress gives us additional dollars, that's a particular area of focus that we're going to continue to work in. Next slide, please. We're excited that this spring, one of these public health scholarship may be out this week, if not today, to support public health students who are interested in going into careers, particularly in state and local entities. It's not a large amount. We anticipate 26 awards going to organizations that are going to provide these scholarships for students who are interested in working in public health, and particularly in those state and local entities. Also, almost $240 million to expand the community health worker cadre of workers across the country. We anticipate with this funding over that period of performance that will expand and provide training to almost 13,000 community health workers and core public health principles. But I think one of the more important things for this program is how do we lever it in the future to bolster that pipeline? If organizations are successful in identifying students, particularly those of disadvantaged background, students of color, who become community health workers or allied workers or paraprofessionals through this funding, can we create ladders and bridges for them to continue on if they choose to enter another health profession, whether that's PA, nursing, medicine, or another health profession to help diversify our health professions more broadly. Next slide, please. And I just want to, a couple other slides here, just share with you publicly available data that we have. Our currency in workforce is data, and it is one of the tools that needs to be enhanced. I think COVID demonstrated to us that we had significant gaps in understanding the capacity of our workforce, whether in an acute setting or in the outpatient setting, whether in public health or in primary care. There were some significant gaps that we hope to address in this year and the years to come in terms of our data. But here's some tools that are available now and that we've externalized. Next slide, please. So I end with in terms of strategies to address community needs. One is developing better tools and metrics for assessing community health work needs. We're able to do that right now at the national, state level, and in some areas down to the county level. But I think where we really need to operate is in that area code level. If we say social determinants of health, the zip code you come from is a bigger predictor than anything else in terms of your future health and well-being, we need to get better about assessing workforce needs at that level. Expanding community-based training, supporting that infrastructure, and facilitating deeper, more meaningful partnerships between academic organizations and community-based organizations to help support that pipeline and wave of culturally competent providers that we need in the future. And let me end there. Hope I didn't take up all the time, and there might be some questions that I'm happy to answer. So thank you very much.